All right, let's jump right into this explainer. Today, we're unpacking a highly dense, anatomically complex topic that honestly plays out like a high-stakes thriller of human anatomy. We're talking about deep neck infections. It sounds like something straight out of a horror movie, but it's a very real medical reality, where the very structure of our bodies can actually work against us, turning a minor issue into a literal race against the clock.
So I want you to think about this question. When does a simple sore throat become a deadly emergency? We all get sore throats, right? A standard viral bug, maybe a bit of strep, or even just a nagging toothache. But there is a critical tipping point, a point where that routine complaint breaches our normal defenses and enters hidden spaces it was never, ever meant to be in. If we don't understand the hidden map of the human neck, things can escalate insanely fast.
To solve this medical mystery, our roadmap is pretty straightforward. We're going to cover 1. The deep neck spaces. 2. The 4 major neck infections. 3. Recognizing the red flags. 4. Life-threatening complications. And finally, 5. Diagnosis and treatment management. Let's get into it. Starting with Section 1, the deep neck spaces. This is basically our map of hidden compartments.
Okay, so the crucial thing to grasp here is that our neck is not just a solid tube of muscle and bone. It's actually this incredibly complex architectural system separated by thin, tough layers of connective tissue called fascia. These fascial layers act like walls, creating distinct, completely hidden compartments all the way down your neck. So when we talk about a deep neck infection, we are specifically looking at hostile bacteria invading these walled-off spaces. And because that fascia is so tough, the multiplying bacteria, whether it's a collection of fluid pus or aggressive tissue inflammation, build up immense pressure. They're trapped, so they start pushing against vital structures and literally destroying the surrounding tissue.
I love this spatial metaphor. Think of these spaces as specific neighborhoods where infections can just set up camp. And some of these neighborhoods are vastly more dangerous than others. You've got the peritonsillar space, which sits just behind your tonsils. The parapharyngeal space, deep on the sides, holding the absolutely critical carotid sheath. The retropharyngeal space, right in the back of the throat. Then you have the aptly named danger space, which is literally an ominous corridor, a highway running straight from the base of your skull right down into your chest. And finally, the submandibular space, tucked right under your jaw and tongue.
Moving on to Section 2, 4 major neck infections. We'll call these the core 4 villains. Let's introduce the specific infections that absolutely love to hijack these anatomical neighborhoods. What's really fascinating here is how each villain has a very specific origin story that maps directly to a physical red flag. For instance, a peritonsillar abscess usually starts as normal strep throat, but it builds up and physically pushes the uvula all the way to the opposite side. Then you have a parapharyngeal abscess. In adults, this might start from a bad lower molar, or strep in kids, and it causes this distinct, one-sided swelling right at the angle of the jaw. A retropharyngeal abscess, often from infected lymph nodes in kids or throat trauma in adults, creates this terrifying bulge in the back of the throat. And then there's Ludwig's angina, starting from an infected lower molar and creating massive swelling on the floor of the mouth and a swollen bull neck.
Now, we actually need to pull Ludwig's angina out and distinctly separate it from the others. Why? Because it isn't a pocket of fluid pus. It's an aggressive, rapidly spreading, tissue-killing cellulitis trapped by that tough fascia. Because the fascia completely blocks it from moving down, it forcefully shoves the floor of the mouth and the tongue backward and upward. It literally has nowhere to expand but right into the patient's airway.
Which brings us to Section 3, recognizing the red flags. These are the symptoms of rapid escalation.
If you are examining a patient, you have to constantly connect their observable physical signs back to the physiological danger that's brewing beneath the surface. It's not enough to just notice a symptom. You have to understand the anatomical mechanics causing it, right? These aren't just uncomfortable symptoms, they are blaring mechanical alarms. Take a hot potato voice. That muffled sound means decreased sound resonance because of immense swelling in the pharynx. It's literally obstructing the sound waves. Severe drooling? That happens because swallowing is simply too painful or physically blocked, so secretions just pool up. And trismus, or lockjaw, means the infection is actively irritating the medial pterygoid muscle used for chewing. It's causing it to spasm so severely that the patient literally cannot open their mouth.
This completely highlights why recognizing those red flags is absolutely vital. It is exactly how we differentiate a standard, routine, viral sore throat from a rapidly escalating, deep space emergency. Look, a normal sore throat does not cause you to forcefully drool or lock your jaw shut. The second you see these red flags, you are no longer dealing with a surface issue. You are dealing with a high-pressure emergency trapped deep inside the neck.
Let's look at Section 4, Life-Threatening Complications. This is where infections break the borders. The absolute climax of our medical thriller happens when an infection breaks out of its initial compartment and weaponizes the neighboring anatomy. These deep neck spaces aren't isolated pockets. They're connected pathways to some of the most vital structures in the human body. Take descending necrotizing mediastinitis. This sequence is a brilliant, terrifying example of anatomy dictating pathology. An infection starts in the throat, breaches the fascia into the danger space, and uses it as a literal highway down into the chest. Gravity, plus the negative pressure created every single time you inhale, literally sucks the pus downward. This leads to mediastinitis, which is severe inflammation around the heart, massive chest pain, and profound sepsis.
And what about parapharyngeal threats? When an abscess sits in the parapharyngeal space, it directly threatens the carotid sheath. Think of the carotid sheath like the main power cable to your brain. If an infection breaches it, you are risking catastrophic cranial nerve palsies, massive strokes, or a literal carotid artery blowout with massive hemorrhage. There's also this nasty bacteria called Fusarium bacterium necrophorum that causes Lemierre syndrome. It inflames the internal jugular vein, forms septic blood clots, and shoots them straight into the lungs, creating what look like cannonball lesions on an X-ray. It's just brutal.
Then we have the ultimate threat of Ludwig's angina. The climax here is asphyxiation. Remember that severe mass effect in the submandibular space? The swelling pushes the tongue superiorly and posteriorly. It creates an immediate near-total airway obstruction. You'll see a patient with this massive, woody, bilateral bull neck. The airway obstruction is so fast and so severe that it becomes an absolute race against the clock to ensure the patient simply doesn't suffocate.
So, Section 5, Diagnosis and Treatment Management. How do we launch the clinical counterattack? It all starts with one golden rule. Airway is king. You don't have time to guess. You have to act based on anatomical knowledge. If a patient comes in with stridor, low oxygen, or profound drooling, you secure that airway immediately. You absolutely cannot order a CT scan or start surgery on a patient who can't breathe. Managing the airway is the absolute, non-negotiable first priority. Everything else waits.
Once that airway is safe, which, by the way, often requires an awake fiber optic intubation because standard paralytic drugs would cause their swollen throat to just collapse entirely, the treatment hierarchy kicks in. The gold standard protocol demands hitting those polymicrobial bacteria with big gun IV antibiotics, like ampicillin sulbactam. But drugs aren't enough. You have to follow up immediately with physical surgical drainage. You need to achieve source control, because antibiotics alone often just can't penetrate a large, walled-off abscess.
When it comes to surgical tactics, surgeons have to rely heavily on their anatomical map. They use the C3 vertebrae and the carotid sheath as critical landmarks. It's basically a high-stakes game of geometry to decompress the space without causing more harm. If the abscess is high up, visible, and safely medial to the blood vessels above C3, they can often drain it using a transoral approach, right through the mouth. But if it's deep, lateral to that vital carotid sheath, or extending below C3, they have to use an external neck approach, going in from the outside, to safely drain it without hitting a major artery.
So, to wrap this all up, how does mapping the neck's hidden borders fundamentally change the way we perceive and treat something as simple as a toothache? Honestly, it leaves you in total awe of human anatomy. It proves that knowing exactly where a disease lives is the ultimate key to stopping it in its tracks. A simple dental infection can become a fight for a patient's life, entirely dictated by the hidden fascia and secret corridors inside our bodies. Understanding this map is what transforms chaos into clear, life-saving clinical action. Thanks for joining me on this explainer. And it leaves you wondering, what other hidden structures in our bodies are just waiting to completely dictate our reality?